Welcome you all to the first inaugural session of what we call critical care par excellence. I am Arindam. This the entire purpose of this forum that we created. It was an initiative of all the leading critical care persona of Mumbai and Maharashtra, and it was initiated by Dr. Professor Rahul Pandit, along with all the 12 branches of ISCCM in Maharashtra itself, their dignitaries, their chairperson, and secretary itself. And all of we, just to recapitulate, we decided that once a month, preferably on the second Thursday of the month, if it is not a public holiday or something else, we will start. We will meet from 8 to 9 and come up with certain discussions, academic discussions, and the format would be there would be certain case presentations, an update of the journals or the recent publications, tech innovations, and some interesting data interpretation slides. So and the responsibility would be rotated. Two of the branches, and we thought that it would be nice to have a branch with larger number of members, and a branch with a lesser number of members would come together and present the entire fiasco. And we all of us will come together and discuss about it. So on the inaugural session, it is prerogative of the Mumbai branch as well as the Nasik branch is going to present. And today we have three case presentations, a journal update, and couple of data interpretation if we have time. And as we have decided that have we will start in time and also we will finish in time. So without any delay, I am inviting Professor Dr. Rahul Pandit to say the introductory words and also introduce our presenters from Mumbai and Nasik branches. Over to you, Dr. Pandit.
Thank you very much, Dr. Arindam, and for everybody, very, very good evening. Thank you very much for joining. I am Dr. Rahul Pandit, and I work with HN Reliance Foundation Hospital. And this initiative is a purely an academic initiative. Arindam has given already a good brief about what we are and what we want to basically achieve as a whole group. I am not going to repeat that. I'm going to straight away start with the introduction today. So we have a first case which will be presented by the Mumbai branch, and we've got Dr. Pinak Pandya, who is a consultant at Department of Critical Care at Jaslok Hospital, Mumbai. Welcome, Pinak. And we've got Dr. Sonali Wadi, who is the chairperson of ICCM Mumbai branch. Dr. Pinak, you can start your case. You have 15 minutes. We would like to stick on to the case for 15 minutes so that we can actually get all the things done.
Good evening, everyone. So my first case as an inaugural session is of a case of a 31-year-old woman. Yeah. She's a 31-year-old lady with no previous comorbid conditions. She had presented to us with 38 weeks of gestation, and her in the pre-gestational workup, she was just found to have preeclampsia, which was detected at 34 weeks. After that, she was on regular follow-ups. She was detected to have incidentally intrauterine fetal demise on the 30th of October. And she came to us, and she had been planned termination of pregnancy on the 1st of November. She was admitted for termination. She was offered an induction of labor or a lower segment cesarean section for termination. And to avoid the trauma of a stillborn baby, she opted for a lower segment cesarean section. The pre-op investigations and the cardiac workup, which was done, was normal. In the operating room, there was induction of anesthesia, which was done, and the GA was administered. As soon as the patient was intubated, there were no signs of ventilation. There was no EtCO2. It went from 40 to 5 within seconds. And there was a mixture of blood and frothy fluid, which was seen coming out of the endotracheal tube. So it was a situation wherein there was a situation of panic despite persistent suctioning and tube change. There was persistent hypoxemia. The patient had low EtCO2 with high peak pressures. Ambu ventilation was tried. All sorts of mode were tried. but there was no response. Following this, there was sudden bradycardia, and the patient was given cardiac massage with injection atropine adrenaline, and frank CPR was started. After 4 minutes of CPR, the patient's hemodynamics recovered, but she had tachycardia, heart rate of 100-120 per minute. She had a blood pressure of 200/100, where it might be an adrenaline effect, and the ECG on the monitor showed ST segment depressions. Invasive lines were secured, cardiology opinion was sought immediately, and a 2D echo was done in the OR, which showed severe hypokinesia in the IVS apex and distal anterior wall with the LV ejection fraction of 15 to 20%. After which an attempt was made to stabilize the patient with diuretics, nitroglycerin, labetalol, nitroprusside infusions, and milrinone to improve the cardiac contractility and output. At this point, the team decided that we have to go ahead with the LSCS and to get the baby and the placenta out, which was initially thought to be the primary cause of the event. A stillborn male baby was delivered, after which there was still no improvement in the clinical condition. So then this was the echo. You can see the LV is barely contracting. There is severe regional wall motion abnormality. In view of the refractory pulmonary edema, the persistent hypoxemia, low saturations, rising acidosis, it was decided that the patient would need some mechanical circulatory support. An initial decision was made to insert an IABP. IABP was inserted to the left femoral artery. Despite this, the above hemodynamic condition persisted, and there was no improvement in the acidosis and the hypoxemia. So a cardiovascular thoracic surgeon was consulted, and he was made to see the patient, agreed. All of them consented that the patient would need an ECMO. As an ECMO would require persistent anticoagulation, the relatives were counseled regarding the high risk of bleeding, intraperitoneal, intracerebral, and they were the risks and benefits were weighted. And then after the consent of relatives, a VA ECMO was initiated. Femoral access and return cannulas were taken in view of emergency nature of the event. The patient's hemodynamics was stabilized after ECMO. The patient was then shifted to ICU on ECMO and ventilatory support. Rest ventilation was initiated and ECMO flows were maintained around 3.5 to 4 liters. Heparin infusion was initiated to maintain the ACTs. Repeat checks were done for detection of any bleeding. TE probe was kept in situ for the screening of the left ventricle. Minimal inotropes were continued to maintain MAP of around 65 to 70. Dyselectrolytemias were corrected, and oxytocin drip was continued to avoid any postpartum hemorrhage. Post-op day 1, there were drop in pressures, hemoglobin dropped. Immediately USG screening was done, which showed there was rectal sheath hematoma, and there was another hematoma at the right pole of a kidney. There was fall in hemoglobin and blood pressure despite transfusion of blood products, with increased drain outputs and persistent soakage at the surgical site. So a joint decision was made to shift the patient to the OR and take up for exploratory laparotomy with ECMO support and IABP support. Massive 4-liter hematoma was evacuated and blood clots were evacuated. Very extensive hemostasis was achieved and the patient was shifted to ICU. She required multiple blood product transfusion according to the coagulation status. The post-op day 2, her condition gradually improved. The bleeding was minimum. She had minimal inotrope requirement. After 24 hours of starting ECMO, the 2D echo was screened and showed that the LV function had improved to around 35-40%. The TE probe was removed and the patient was awakened, and neurological examination detail was done, which revealed no focal deficit. She had good urine output with pulsatile flows and improving general condition. No major bleeding episodes. Gradual weaning of the ECMO was commenced from post-op day 3 onwards. IBP support was still kept at full support. On post-op day 3, the ECMO decannulation was done. On post-op day 4, the bedside screening echo was done, which showed EF of 50%. So it was decided to remove the IABP, and gradually she was extubated on post-op day 5. Subsequently, on post-op day 7, she was shifted to the room. Drains were removed gradually as per the surgical team, and 2D echo prior to her discharge showed complete recovery of LV function. So at this clinical scenario, 3 possibilities were considered: acute coronary syndrome causing coronary artery dissection or coronary artery occlusion, considering the hypercoagulability state, Takatsubos, or a peripartum cardiomyopathy. I'll just throw light on some peripartum cardiomyopathy. It is acute and sometimes severe cardiac degeneration that occurs during pregnancy or early postpartum period. It's defined as maternal heart failure with systolic dysfunction characterized by LV failure, LVF less than 45% that happens in the last month of pregnancy or till the first 5 months after delivery. The risk factors are hypertensive disorders of pregnancy, multiple gestations, advanced maternal age, and anemia. Mode of delivery like LSCS is not considered as a risk factor. Usually the presentation is like heart failure, orthopnea, dyspnea, elevated JVP, pulmonary rales, and edema. But sometimes the presentation can be accelerated and catastrophic, like a cardiogenic shock or a cardiac arrest. Infrequently, the patients will present with complications like arrhythmia or a thromboembolic event as well. The diagnosis requires a high index of suspicion and is often delayed because most of the symptoms mirror those of pregnancy itself. Now, what is a differential diagnosis? Either a pre-existing cardiomyopathy or a preeclampsia without an absence of systolic dysfunction, pulmonary or amniotic embolism, valvular heart disease, congenital heart disease, chemotherapy-induced cardiomyopathy, spontaneous coronary artery dissection, myocarditis, Takatsubos, tachycardia-induced cardiomyopathy, pulmonary edema result from tocolysis, sepsis, and aortic dissection. Pathogenesis, usually it is a mixed theory. The pathogenesis is not very clearly understood, but most of them end up in a hormonal imbalance. The hemodynamic changes of pregnancy, as you see, they increase plasma volume from the third trimester, and they increase the cardiac stroke volume, which occur during the final trimester. These changes are temporarily discordant because the cardiomyopathy does not occur in the final trimester. It occurs just before delivery and lasts for 5 months post-delivery. So the late gestation and postpartum period are characterized by profound change in hormones, and they usually land up in cardiomyopathy. The incidence is around 1 in 1,000 for in US, and it comes down to 1 in 100 for third world countries like Africa. The theories are it can be myocarditis, but it's not proven. It can be genetic predisposition. The most common gene affected in cardiomyopathy is peripartum, a TN gene. Other theories are microchimerism. It can be a role of inflammation. It can be a selenium deficiency, chemotherapy, or alcohol use, or autoimmunity. But most common is it's the beautiful diagram which highlights the hormonal changes which start from the pituitary, which shows that there is mainly high activation of prolactin, which causes all the VEGF, all the progesterone to get activated, relaxin to get activated, and it finally causes cardiac failure. General principles of management start with anti-failure therapy, but we have to be careful. The patient usually does not present with IOFT, as in my case, but we have to be careful of the drugs that we use because the patient might have a live baby inside. So we can't use ACE inhibitors, diuretics, nitrates, AT blockers, androstenedione antagonists. So they all have to be used after delivery. So what we can use is labetalol, we can use hydralazine plus isosorbide. There is no data on newer agents like ARNIs and SGLT2s, but they have to be used after delivery. Advanced therapies can be used like mechanical circulatory support, percutaneous ventricular assist devices, or ECMO. Other important points to be noted in such cases is there has to be low threshold for initiation of anticoagulation. Temporary defibrillators can be used to prevent and treat arrhythmias. We have to have a multidisciplinary team. Like in this patient, we had a post-op day 1 complication which immediately needed re-exploration. Bromocriptine, it has been studied extensively to suppress prolactin release from pituitary, but none have derived any conclusion. There is an ongoing trial called Rebirth trial, whose results will come in 2026, which might throw more light upon this. And many centers are now suggesting genetic testing for such high-risk patients. Outcomes in most women, LVF increases to more than 50% in 6 months. LVAD is needed for around 10% of patients, but mortality is as high as 20%. Predictors of worst outcome are late presentation, more than 1 week after delivery, late gadolinium enhancement on MRI, left ventricular dilatation along with dysfunction and presence of RV dysfunction. Little evidence supports use of long-term heart failure medications after ventricular function improves, but usually they continue till 1 year. Counseling is very important because we have to limit further deliveries in such patients. We have to also do genetic testing for families. So peripartum cardiomyopathy is a challenging diagnosis to confirm and differentiate. Pathogenesis remains poorly understood, but genetic testing suggests that the peripartum cardiomyopathy may lie on a spectrum with dilated cardiomyopathy. Many of the genes which cause DCM are the same that cause peripartum cardiomyopathy, and genetic testing should be offered. Management largely mirrors the guideline-mediated therapy, which is for medical treatment for HFrEF. The ongoing RCT is currently ongoing, which evaluate the use of prolactin suppression as a therapeutic approach. Short-term prognosis is usually favorable, but a subset fare poorly and face chronic heart failure, which needs transplant. Long-term patients may also face mental disorders like PTSD and depression, so counseling remains a key. This was my patient's echo before discharge. It shows improvement in LV function. Thank you.
Fantastic case, Dr. Pandya. I think this sort of highlights the uncertainties which you see in our intensive care and medical practice on day-to-day basis. And I have seen such cases at least on 7 or 8 occasions. Not every case has needed ECMO, but we've had cases being referred to us from smaller hospital. We've had cases which have happened in our hospital. And one thing which so whenever I talk to a gynecology or obstetric crowd, one thing I tell them that there is always a defense that pre-op all the functions were normal. They will always put up that defense. Now they are the ones who have the PCPNDT license. All of the obstetricians in Maharashtra at least have the PCPNDT license given to them. Majority of them, maybe 90% plus, do their own ultrasound. And I tell them just use the same probe onto the chest and see if the LV is actually contracting well or not. You don't need to know anything else, whether the contractility is good or not. And if it is not, I think that's the time to call the cardiology friend and get a proper echo done. So cases where IUFD has happened, cases where there is a complication in the pregnancy, my suggestion to all of you would be that put a quick echo probe and see for yourself what is the contractility of the heart. You would be surprised at the number of cases who actually have a poor ejection fraction, which is unknown to the family, which is unknown to the treating obstetrician as well, and very well managed. I think the beauty of this Pinak is that as soon as the ejection fraction improved, you wean the patient off on day 3. There is a lot of it takes a lot of guts to wean off a patient from VA ECMO on day 3. I have seen number of cardiologists struggling with that decision, even when the ejection fraction is looking good, because there is a fear that it may actually be a phenomena which is just ECMO supported, and as soon as you take it out, it would worsen. And of course, IABP always helps. I would take
Yes.
2 questions from the crowd. Let's limit it to only 2 questions so that the Nasik branch can present the next 2 cases. 2 questions, 2 minutes. Anybody has a question? Anybody
Sir,
has
I
a
have a
comment?
question. If there are no questions to Dr.
Absolutely. Go
Pinaki.
ahead. Go ahead.
Okay. Is there any chance of recurrence for a PA? What was your literature suggesting on that? If the person has
Yes.
already suffered, and is there a recurrence in the subsequent pregnancy?
Yes, sir. The disease recurs in 10 to 50% of cases. That is the literature which is saying. So the counseling is very important. The counseling should be done that if the patient is having such sort of event, go for a tubectomy or something which will prevent further pregnancies in the patient. And second, do a genetic testing in the first degree relatives.
And
And
regarding the prolactin,
Yes.
whether the prolactin is given after the onset of the failure or itself, or it is a preemptive approach.
So if the patient has high risk pregnancies, usually if the LV is good and the patient is taken on table, unless there is a sign of failure, sir, we don't initiate bromocriptine in such patients because till now the data suggests that bromocriptine does not prevent cardiac dysfunction. But an RCT, as we know, as I told, a rebirth trial is currently happening in the US, and whose results will come in 2026, which will guide us further on use of bromocriptine and when is the ideal time to use.
So, Dr. Arindam, one more thing. If it is a Takotsubo's cardiomyopathy, stress cardiomyopathy, the incidence of it happening after it has recovered is a little bit less. But the cardiomyopathy, which is this typical peripartum cardiomyopathy, which happens, I think the incidence is significantly high. Dr. Yogesh L, you have raised your hand. Yours is the last question. Please go ahead and ask your question. Dr. Yogesh
I
L.
guess, yeah. I guess this is a prolactin suppression that has been tried in the trials, but it will be very
Yes.
difficult to see which patients like it is going to help, because it is very unpredictable which patients are going to go in the cardiac failure.
Agreed,
Can
sir.
you
I don't
highlight
think we
more
should be
on
using it
that
in the
trial?
preemptive. So we should not be using it preemptively. I completely understand that. And
Exactly.
even prospectively after cardiac failure has set in, I think bromocriptine is a reasonably safe drug to use. But as Dr. Pinak was saying, the evidence for that is very sparse right now. And whatever you would be using would be on the based on the experience and your own thought process.
Because
I completely
bromocriptine
agree
is
on that.
just bromocriptine mainly hyper stimulating ovarian syndromes that has been like given results bromocriptine, but that way it will be very difficult to choose like in which patients it need to be used or something that way.
Yes, agreed. It is not
Sir,
a straightforward answer.
sir, one last.
Hmm.
Sir,
Go ahead.
is there any role for serial prolactin measurements if we are using as a surrogate marker to predict those patients who are probably going into cardiomyopathy?
No,
I don't
prolactin level
know.
doesn't correlate.
Yeah,
Prolactin level doesn't correlate with severity of cardiomyopathy.
I don't think the prolactin level has got any correlation. That's the whole reason why maybe bromocriptine actually does not work at all. So Pinak, fantastic. Thank you very
Thank
much. I think
thank you.
it is a fantastic opening for the academic session. Very, very good case. And we really
Thank you.
appreciate you coming and presenting it for us. Thank you very much. So I'll invite now the second branch, which is the Nasik branch today, and it is represented by Dr. Dinesh Wagh and Dr. Yatindra Dubey. Dr. Wagh is the chairperson of IICCM Nashik branch, and Dr. Dubey, we all know, has been the past president of Nashik branch, and he's a well-known faculty in the critical care circuit. So, Dr. Wagh, would you like to start up with the case, or is it going to be one of your students who is presenting it, sir?
No, I will be presenting the case, sir.
Excellent.
Yes. So,
You can
great.
share the slide.
Yeah.
And Dr. Dubey, are you there, sir? I saw him log in some time ago. Yeah, I
I'm
can
there.
see.
I'm there.
Ah, hi, sir. How are you?
I'm audible, sir.
Yeah. So this was a 87-year-old male. He doesn't have any diabetes, hypertension in the past. He presented he presented with the complaints of post discharge from the pacemaker side, and with prior to that he had a history of PPI insertion CHB in July 2022. Then he needed a revision pacemaker lead replacement in 2023 May. And then again, he was admitted for the pocket revision surgery almost 3 months back for almost 5 days from 22nd of March to 29th of March. At that time, debridement was done, and he empirically received the ceftriaxone, amikacin, and levofloxacin. He was discharged quite comfortably at that time, and then again he developed the similar complaints. So he got admitted to another hospital from 2nd of May to 27th of May, almost for 20 days. At that time, again, the revision surgery was needed. and his pacemaker was again surgically fixed with the another side with empirical antibiotic which he received, meropenem, teicoplanin, daptomycin, and fluconazole. He was discharged again with the IV daptomycin. Pus culture, which was suggestive of staph MSSA, was isolated at that time, and Candida glabrata, which was sensitive to fluconazole, was isolated. Now he again developed after 8 days of homestay. He again developed the symptoms, and he presented to me with his complaints of dyspnea, dry cough, frequent micturition, severe hypoxemia, bilateral pedal edema with saturation of around 70% on room air, which was always he always kept to be normal as per the history. BP was 130 by 78 millimeters of mercury, and RS was suggestive of bilateral Krebs. Yeah. Yeah, this was the CT scan, which was suggestive of bilateral ground glass opacities with some reticular with fibrotic shadows. This patient never had breathlessness prior to this admission. So, and his other investigation, his hemoglobin was 11.8, WBCs were 22,000 with differential counts of around 70% neutrophil with 7% of eosinophil. Platelet counts were normal. His procal at this time was also normal. His proBNP was around 385. And otherwise, other lab parameters were almost normal. So looking at this CT scan, we decided to go with bronchoscopy. So bronchoscopy was done in the ICU. Ball sample was sent. Blood and urine cultures were sent at this time. Similarly, as the CT scan was suggestive of some kind of interstitial pneumonia, so flu panel which was sent, which came to be negative. His respiratory PCR for even COVID-19 was negative. 2D echo was normal. His BAL, which came to be around 15% of eosinophils were seen in the BAL. There was no AFB, no other organism grown on culture, and cytology was negative. So for me, for this case, the differential diagnosis was either it can be acute NSIP, it can be a viral pneumonia, or it can be a drug induced, or it is just a flare of another infection which was there, which was sitting there with the pacemaker site. So he was started with the broad spectrum antibiotic, meropenem, teicoplanin, and caspofungin with low dose of steroid and supportive care. With gradually, as per his FiO2 requirement, he was put on HFNO as well as alternatively BiPAP. With around day 5 of treatment, the O2 requirement and dyspnea reduced, while his WBC counts also reduced. CRP started downtrending, and he was shifted to wards within 5 days. His day 5 to day 10 was uneventful. While on day 10, again, he developed the worsening of dyspnea, drowsiness. His ABG was suggestive of hypoxemia and CO2 retention. He was shifted back to ICU. Repeat cultures were sent in view of clinical worsening, and his antibiotics this time were again broadened with ceftazidime, avibactam, aztreonam, teicoplanin, and caspofungin was continued. He was clinically better in due course of time. His FiO2 requirement decreased, but as he required lots of recurrent admissions in last 2 months, relatives and the age relatives wanted to take him home, so they took the DAMA discharge. So in this case, sir, can you means my suspicion for this case was whether it can be a acute atypical pneumonia like NSIP. It can be a viral pneumonia, even though his H1N1 and COVID was negative. But his BAL was suggestive of around 15% of eosinophil. So daptomycin, which was the drug which he received even for more than 4 weeks of duration. So I thought that whether this can be a daptomycin-induced eosinophilic pneumonia. So I went through the some literature about daptomycin. Daptomycin, as we all know, that it is a lipopeptide antimicrobial antibiotic which acts against both aerobic and anaerobic gram-positive bacteria. It acts by calcium-dependent depolarization of bacterial cell membrane, causing the release of intracellular potassium and cell apoptosis and cell death. It is usually used against the MRSA, and vancomycin-resistant enterococci for skin and soft tissue infections, as well as infective endocarditis or osteoarticular infections. It is avoided usually in the bronchoalveolar pneumonia because of its inactivation by the alveolar surfactant by its binding to it. So mechanism of action, as we already discussed, it is not usually useful in respiratory tract, but in urinary tract, it achieves the good concentration. So usually the complicated gram-positive or anaerobic gram-positive infections of urinary tract, that is usually used in urinary tract infection. CNS, it doesn't have much penetration, while soft tissue and bone and joint, it is commonly used. So dosing is around 6 milligram per kg body weight IV every 24 hours for Staph aureus bacteremia associated with other either complicated skin or soft tissue infections or right-sided endocarditis. In renal impairment, usually if creat clearance is more than 30 ml per minute, then it is given every 24 hours. If it is less than 30 ml per minute, then 48 hours. In dialysis patient, daptomycin can be given 3 times per week following the dialysis. The common side effect for daptomycin is usually myopathy. The risk factor for myopathy usually baseline renal impairment or concomitant statin administration or obesity. The clinical manifestation ranges from mild myalgias to chronic myopathy with severe weakness to massive rhabdomyolysis in acute renal failure. So drug-induced eosinophilias are are also known to cause in cases of daptomycin side effects, where from DRESS syndrome to primary eosinophilia also can be seen. Nausea, vomiting, neutropenia, and DEP is one of the most concerning side effect of the daptomycin. So how to differentiate the DAP and why the DAP is daptomycin-induced pneumonia is observed. Accumulation of daptomycin binding to the pulmonary surfactant may cause the cellular damage, which leads to the oxidative injury and lung epithelial inflammation. Alternative, daptomycin may induce the allergic reaction, causing the release of T cell lymphocyte followed by interleukins and eosinophil migration, leading to the interstitial pneumonia and eosinophilic pneumonia. The incidence is quite rare, around 1.7 to 4.8%. 3 types of eosinophilic syndromes have been described. Usually, the peripheral eosinophilia, primary daptomycin-induced eosinophilic pneumonia for about 4 weeks in patient who is on therapy, or daptomycin-induced related re-exposure leading to daptomycin-induced pneumonia. The risk factors for DEP is usually the age, which is more than 70 years, and treatment duration for more than 14 days, or total cumulative dose, which is more than 10 gram of cumulative dose of daptomycin, increases the risk of developing the daptomycin-induced pneumonia. Elevated peripheral eosinophils. If patient has elevated eosinophils in peripheral blood, more than 5%, which was also supposed to be a risk factor for in those patients, it has to be taken into concern, and one should always think of not using daptomycin as a drug for treatment in that specific patients. Male sex predominance and baseline renal dysfunction is also a risk factor for developing DEP. The diagnostic criteria which are proposed by the FDA for DEP include the fever with dyspnea, with increasing oxygen requirement, with new infiltrates on chest X-ray or CT scan, on concurrent exposure history of daptomycin, along with the 25% eosinophils on BAL and clinical improvement with the withdrawal of the drug is the diagnostic criteria of daptomycin-induced pneumonia. The onset of fever and dyspnea and hypoxemia is usually between 2 to 4 weeks of exposure to the daptomycin, but can manifest subacutely as well in some patients. Chest X-ray usually demonstrate the pulmonary infiltrates. The other findings could be bilateral diffuse ground glass opacities, pleural effusion, subpleural reticulonuclear opacities also are seen. The mainstay of treatment is discontinuation of daptomycin and supportive care. Usually, the patient, once the patient is off daptomycin, means is off the daptomycin, symptom improvement is expected within 24 hours to 1 week of daptomycin discontinuation. The role of steroid remains controversial despite of their ability to cause the eosinophilic apoptosis. Some The regimen of the steroid outlined include intravenous methylprednisolone 60 to 125 milligram every 6 hourly, followed by tapering dose of oral prednisolone of 40 to 60 milligram daily over 2 to 6 weeks has been used in some patients. Thank you. Hello.
Thank you very much. Another very, very good case. Unfortunately, we don't know the complete diagnosis whether your case actually had a daptomycin induced eosinophilic pneumonia or not. But certainly, I think this is something which we very often do not think of as a diagnosis when we are starting patients on daptomycin and they worsen secondarily. And I think you brought out a very comprehensive point about daptomycin and the association of eosinophilic pneumonia with that. We will take one question, sir, if at all anybody has a question, and then we'll move on to the case from Dr. Dubey. And then if we have time, we can take some question at the end of the second case as well. Any questions for Dr. Wag? Any comments? All right, Dr. Wag, we'll come back to you. Dr. Dubey, sir. Hello. Welcome, sir.
You,
You can share your slides, sir, and we can start with your case.
Thank you very much. Now, this is the case, what we saw nearly 1.5 months back. He was a 66 years old male patient. He was a known case of diabetes and hypertension for nearly 6 years. He was on gliptide, metformin, and amlodipine. He had history of psoriasis, but he wasn't on any medications, and his lesion was well managed. And he was admitted at other center with history of fever, joint pains, and myalgia, which was there for nearly 2 days. He noticed loose motion, which was 5 to 6 times. It was watery. There was no blood, no mucus. He complained of abdominal pain, which was severe in both lower quadrant, and he felt extremely weak and extremely fatigued. And he was started on Oflox, Metrogyl, and IV fluids. On day 2 of admission at other center, he was found to have puffiness of face, edema of feet. His BP dropped to 60 to 70 systolic. He was given fluid challenge. He was put on vasopressors. And surprisingly, he was found to have a severe hypoglycemia, repeat the hypoglycemia. And last dose of OHA was given nearly more than 72 hours before. So this was very intriguing why still he's going hypoglycemia at the end of 72 hours. It was a progressive disease. There was a progressive drop in urine output. He had hypoglycemia, and that's how he was shifted to our center. History-wise, there was no history of headache, convulsions. There was no history of hematemesis melena. There was no history of shortness of breath, chest pain, syncope, or coronary artery disease. There is no history of similar episode in the past. There was no history of smoking. He did give history of alcohol abuse. During the history, we found that the daughter and the wife, both of them had minimum rash and they had some redness of the eyes. So when we saw his heart rate was 110, BP was 80 systolic on vasopressors, he had puffiness of face, edema of feet. There was redness in the eyes. There was maculopapular rash over face and some part of the upper limb and lower limb. And cardiovascular examination, chest and abdominal examination was unremarkable. So at that time, differential was acute febrile illness. There was a history of enteritis, and following which he went into the shock and multiple organ dysfunction. The odd point was rash. Second odd point was history of similar illness in the family, and history of puffiness of face, whether it was a fluid or it was a capillary leak. So initial thought process in ER was whether it's a sepsis, but there are a lot of odd points. Why both the daughter and wife, she had the similar illness. And looking at the story, very rapid progression and the hypoglycemia, what we usually see during sepsis is always accompanied with the other signs. Whether it was tropical febrile illnesses, the point against dengue hemorrhagic fever was conjunctivitis. Leptospira, history-wise, it was inconsistent. Parvovirus is uncommon, we did keep in mind. Chikungunya, sudden acute onset, and no other person in the family or in the adjoining area had the similar illness. Malaria, the area from where he comes is usually is not seen, but we did keep a differential. Scrub typhus was very common over there. And other etiologies were definitely in mind because so many things looked unexplained at that point of time. And whether it was a drug induced, we looked up the entire drug history and we could not find etiology. Autoimmune, first episode, and the wife and daughter both had the similar illness. So again, it became more in favor of other etiologies rather than autoimmune. We sent the labs and his hemoglobin was 14, platelets was 1.21, sugar was 60, create was fine, electrolytes were okay, enzymes were slightly on the higher side, iron was okay, triple H was negative, NT-BNP was 1900, procal was 6.6, and his ABG-wise his lactate was 3.8, bicarb was 21, and he was hypoxic. This was the X-ray taken in AR. X-ray ECG was showing sinus tachycardia. We did an echo. We showed good LV and RV function. IVC was dilated and less than 50% collapsing. For next 48 hours, he was on NIV. We gave him diuretics. He was on doxycycline, ceftazidime, avibactam, astronome, and metrogyl. The idea of adding ceftazidime, avibactam at that point was we were not very sure about the sepsis part. Falsigo, he already received before coming to us. So he already received 4 doses. So we continued the another dose and we stopped afterwards. We did send his PCR and multiple PCRs showed Zika virus. Now, at that point of time, I had not seen a single case of Zika virus. And whatever I had read, it was all blurred image in my brain. Since he was having a persistent hypoglycemia, we did his cortisol and pre-T4 TSH, which was normal. So looking back again, so sepsis looked one of the differential, but less likely. Now Zika virus, I had never seen this case. Multiplex PCR, the sensitivity is to the tune of 90%. IgM antibody cross-reacts even with the other Flavi group of viruses like dengue, hemorrhagic fever. And usually it is positive in the second week. We looked up the entire review of literature, and it was the entire review of literature, what we could see on day 1 and day 2, that it is a very benign disease and it doesn't cause any problem, and morbidity is very low and almost everyone improved. He was fitting into the case definition, and wife and daughter, both of them, we sent multiplex PCR, both of them turned out to be negative. Whether it was a myocarditis or whether it was a capillary leak. He had, we informed the Nasik Municipal Corporation, NIVT was informed, and they came and collected urine and blood samples both. We did keep Zika virus as a possibility, but other differentials were always there in our mind: dengue, strep typhus, malaria, whether it was HLH, and microangiopathy. Day 3, his shortness of breath increased. He required more oxygen. And EBG wise, lactates has come down, bicarbonates was corrected, and PO2 was around 70-75. X-ray showed a progressive deterioration. His NT-BNP went up to 15,000 to 20,000. Creatinine was borderline high, around 1.8 to 2. LFT's enzymes were raised, and ferritin came in the range of 8 to 10,000. This was the X-ray, and this was a CT scan what we did it. So echo finding when we repeated again, so there was a LVF drop to 20-25%. There was no regional motion abnormality, and IVC has come down to 8 to 10 centimeter. Now this was it's a very busy slide. I can just sum it up. There was a progressive drop in platelets and which started improving. Creatinine dropped for a few days and then it started improving. LFTs was deranged for a few days, it started improving. The only astonishing point for us was ammonia, which was 180 to 200 to 300. And that was making us feel possibly it's all because of the underlying situation what he is. Day 6, he went into acute delirious state. And day 7, he was tapered off from ventilatory support. He was on oxygen. He was still on vasopressors. Urine output improved. LFT improved. Ammonia was still on the higher side. Next 2 weeks, he has a near total recovery. Only he was complaining of severe asthenia. And since his son-in-law was a gastroenterologist and son was a physician, so they kept on making me do ammonia, and that remain high, and they remain high till even now after 2 months of illness. LFT, RFT improved, X-ray improved, and other labs improved. Now the question was when he was discharged, then what are the advices what we can give? He should avoid sexual practices for nearly 3 months, and he should not because the transfusion via blood is one of the mode of transmission. So he was asked not to give any blood product. So this was something was different thing for us, and it was a latest newcomer. This was an article what I saw. So did we think of Zika virus infection when we saw the patient? We never thought of Zika virus infection when we saw the patient, and we were not sure what we are dealing with when we saw in ER, anyone in first 24 hours after the thing. And even when we got the multiplex PCR, that time also we did keep the possibility that 10% of time it can be false positive. Did we anticipate? Possibly no. Could we prognosticate? In fact, I looked up the entire literature. Morbidity is 1.6%. I looked up the entire epidemic of Thailand, Cambodia, and Myanmar. And believe me, I could not, everyone said that it's a very benign disease, a self-limited disease, and the patient do well. It was a learning lesson for me. So Zika virus, as you know, is most of the time the moment we say Zika virus, we say it's more of a neurotropic virus. And ultimately, most of the presentations are Guillain virus syndrome, transverse myelitis, meningoencephalitis, and pregnancy-related microencephalopathy, CIDP, neuropsychiatric manifestation. Diagnosis is by RT-PCR, IgM antibody, but the morbidity is around 1.6%. The two things which, when I was looking at the entire literature, which really made me think to learn, was a ITP, severe thrombocytopenia, and which was something described a lot in this entity, and they all were treated as a immune thrombocytopenia. Myocarditis and pericarditis has been described. Pregnancy and Zika virus. In fact, there's a one mode which epidemiological is one of the very important part of this, because only 18% of them will have a symptom, 1/8, and 80% will not have symptoms. So the transmission to the fetus is going to be definitely a good number of cases. A lot of literature from one of the Chinese literature where they found there was a good number of cases of microcephaly, and when they traced from a certain area, then they found the Zika virus was one of the reasons. Now, this was the thing I could get from PubMed. Transient myocarditis associated with the acute Zika virus, pericarditis associated with the acute Zika virus. Now, one more literature I found Zika virus was isolated even in those who underwent the organ transplantation, and the presentation was unexplained thrombocytopenia and abnormal graft dysfunction. Of course, the graft dysfunction improved over a period of time. Sickle cell anemia and Zika virus, it is one of the bad combination. They are more prone for getting this infection. ITP, I already discussed about that. In fact, when I looked at the literature, there are a few cases have been described in the patient presenting with the multiple organ dysfunction syndrome in the Zika virus. So it was a learning lesson for me when I saw this patient in AR. It was a journey of understanding it's a self-limiting disease to a disease which has a significant morbidity and the asthenia. Thanks a lot.
Thank you very much. Fantastic case again. I think all the three cases have been really fabulous. It gets just kept on getting better and better. I cannot have any other words to say, but I think this was a fantastic case. Zika virus, I haven't seen one. I'm sure there would be only a few of them on the crowd as well out here. We've got around 85 people who have logged in who have seen a Zika virus. If anybody else has, they can share their view on this one, or if they have a question for Dr. Dubey. But otherwise, I haven't seen a Zika virus case yet. Anybody else who's seen a Zika virus case? So I think Dubey sir, it basically talks about a self-limiting disease which sometimes can cause you a problem which will be a morbidity rather than a mortality and stays with you for a long, long time to come
Yeah.
and then becomes sort of a hindrance for a patient to go back to its normal life.
Yeah. In fact, the risk of transmission is for 3 months. Blood transfusion, urinary transmission, and even with the genital transmission. There was a
Yeah,
three and uveitis and the blindness. In fact, when I was looking at the literature, to my surprise, they have described cases of blindness also, which really made me startled. I was entirely amazed with those findings.
fantastic. So can I request all three speakers? So we are all just 3 minutes short of 9 o'clock. So we won't do the other two things today. But we would definitely want the next time onwards, we'll stick on to 15 minutes per case. But we had very, very interesting cases today. So I think there was hardly any room for not doing a complete justice for these cases. All the three speakers did a very, very good justice. I don't want a case PDF, but whatever literature search you did on these D3 diseases, if you want to share with the crowd so that they can be enlightened and they can actually know about Zika virus, about daptomycin-induced and eosinophilic pneumonia, as well as about peripartum cardiomyopathy, where they could read from. I think one slide of that, if we could share on this forum, so that over the next.
Pandit sir, rather I would say that let
Mhm.
them choose a review article what they have gone through
That's what I'm
and
saying.
put it
Review
in the
article
CAM
also.
group, in the article, and put it
That
in the
also is
WhatsApp
fine.
group.
That is also fine if they can just put up one article which sort of sums up most of the things so that other people can read that and would be enlightened and they could sort of go do their own research as well. But fantastic one. Thank you very much, everyone. Thank you very much for joining. Thank you. Bye bye. See you.